Hello, everyone. Welcome to our last session for the day. Give some folks another couple of seconds to hop on here and we'll go ahead and get started. Hopefully you just some of you came off of that cool bingo that we all just did. Hope you enjoyed it. Fun committee. Was really happy that we had a pretty good turnout. So I'll speak for Deb and the team. Thank you to those that helped put that together. All right. We're well over 50, and in the interest of time in these housekeeping notes, I'm going to get started. Good afternoon again and welcome. My name is Anthony Felipe. I'm the director over the South Region Education part of the chapter, and I'd like to welcome you to this last federal legislative panel. Just a quick thank you again to our chapter sponsors. Without their contributions and support, we wouldn't be able to put together some of these events. And then hopefully again here back in person and having some fun where we all belong. Just keep quick reminder again, if you need CPE credit, you're going to need to make sure that you utilize the link and update your name in the Zoom so that we can track your attendance so that you get your credit. You're also going to need to please answer the 3 polling questions throughout this presentation in order to get credit. If you're dialed in, again, you won't be able to get credit. So please utilize the link that you received in your calendar invite when you registered. About 48 hours after the end of these sessions, you'll receive a survey that will contain a link to the recordings as well as a survey to complete in order to get your certificate for credit. Questions wise, as we go along, this is going to be an interactive session with a lot of topics that I'm sure that I'll speak for Kathy and Sean that they'd like to get some feedback and some interaction. So please feel free to put those in the chat function, and either Kathy, Sean, or myself will read those out and address those if there's time. So without further ado, I'd like to introduce our 2 panelists at the moment. We're hoping that Jamie can join us here in a moment, but to get started, Kathy Reep and Sean Stack will take us off here. So Kathy, all yours. Thank you so much.
Thanks, Anthony, and welcome to those who were able to join us this afternoon. I heard that the bingo was great fun, and I really enjoyed the panel earlier this morning that Candy led. So I appreciate y'all joining us. I've been speaking for the Florida chapter of HFMA and have been past president. So I think y'all know me. I am no longer with the Florida Hospital Association, but I'm fortunate to be with PYA. We have an office in Tampa, but get to work from home, which is always great. But I also feel very fortunate this afternoon because an old friend, I emphasize old because he does have his age behind him on the screen.
Oh, whatever.
Sean Stack is going to be my partner in crime for now because we hope that Jamie Caldwell from the South Florida Hospital Health and Hospital Association will be able to join us, but there's an internet issue and power outage. But I worked with Sean when he was at the Ohio Hospital Association, and I would like you to get to know him, and hopefully he will be a frequent visitor for the Florida Hospital, for the Florida HFMA as well. So Sean, would you give a little background?
Absolutely, Kathy, and it's so nice to be with you again. I've always enjoyed working with Kathy, and Kathy and I used to have a show that we used to do in Ohio together called Medicare 101 and 102, and we always enjoyed the time that we spent together there, and our members got so much from Kathy's expertise when she would come into town and help me out with that. So it's great to be back with Kathy again. I am actually the newest member to the Healthcare Economics and Policy team here at HFMA. I've joined, Todd Nelson, who I'm sure most of you know, and Chuck and Katie, who do a great job. And so I joined the team, earlier this year in February, and really have been hitting the ground running with all these rules and proposed rules and final rules and all these, interim final rules that are coming out now on surprise billing and just really getting caught up here and trying to help the hospitals as much as I possibly can. This is my 3rd conference at presenting at just today. So I'm warmed up here and I'm ready to go. But I came from an academic medical center here, in Ohio. I was director of finance there for not 8 years. And then I went to a designated cancer hospital in Columbus, Ohio, and was there a few years over access and scheduling and inpatient and outpatient clinics. So that was a great time, and just happy to be here with you guys today. So turning it back over to you, Kathy, that's a little bit about me.
Well, and the one thing that I will say about Sean, when the various folks that we worked with through the hospital associations, Sean was very much like me in terms of he's in the weeds. And he gets into, did you see page 483, the third line in the second column? And so it's good to have someone else who likes to do that. And I actually see on the screen several people, I won't mention Rebecca and Natalie by name, but who are kind of in the weeds that way too. And so thank you all for having your cameras on. So the first issue that we wanted to talk about this morning is one that we don't hear a lot about. We keep hearing things about no surprises and transparency and proposed and final rules and things like that. But there's an issue of PAYGO. And I don't know how many of you are familiar with PAYGO, but if you aren't, you should be, particularly right now, literally right now, because what we're dealing with, this is a statutory requirement under the, I love this, Congress, thank you for all the great names for things that you do, but it is the Pay As You Go Act of 2010. So PAYGO, Pay As You Go. It's not a short, but P-A-Y, Pay As You Go Act, PAYGO. And what PAYGO calls for is if the spending within the federal government is going to have a significant increase in the budget deficit, and you know that we have a significant deficit right now, and it seems to be getting larger as we speak, that if there is not legislation to increase the deficit, then all of a sudden they have to identify ways to cut spending. And you know that hospitals and healthcare providers are often a target for that. Currently, my understanding of PAYGO is if we do not have an extension on the deficit by September 30th, which is next Thursday, a week from, following, next week, if we don't have an extension on PAYGO, then we could be looking at a required mandated statutory 4% reduction in Medicare spending. That would be effective fiscal year and a 4% cut to your spending. So from a budget perspective, those of you who work on budget, I think that becomes an issue of concern. Now, I did hear this morning that while there is, I believe in the House, legislation to increase the budget, the allowable budget deficit, Senator McConnell has said no, that there needs to be a definite window. We need to curtail spending. So we're not sure what we're going to get out of the Senate, and we only have a few days left. So with that, I've given you background. Sean, your thoughts and what you're aware of related to PAYGO and where we stand. I mean, I would jump in and just say, one more pandemic challenge.
Yeah, I agree. And the current political climate is still a little dicey in DC. And I think everyone is on pins and needles to figure out what they're going to do and what they're going to pass. And if that support will be there, because that 4% reduction in pay is going to be significant. And also keep in mind for everyone keeping track here, the additional 2% sequestration that will be coming back or that come back. So that's a cumulative 6% there in a reduction in pay that could really, hit our budgets hard as hospitals, as providers, and something that we really need to make sure we're watching closely and, communicating up the chain. So we're all prepared for that. In addition to, PHE requirements, PHE stresses on financials, the still looming pandemic. I mean, all these factors are things that we need to take into consideration in our solvency and our, providing very important services to our communities.
Thanks, Sean. And I don't know if others who are in the group have things to share since we are short 2 panelists, but I just want to make sure that if you have items to add, either put it in the chat or let us know. I guess on the issue of PAYGO, because it was addressed, it is literally being addressed today in terms of media coverage because of McConnell coming out and saying that he does not. That basically, I want to say he doesn't support, but there are not the votes in the Senate to, at this point, support the significant budget deficit increase, that they are looking at. So we don't have a lot of time. I urge you to pay attention to what's going on in DC right now, because huge impact on your hospital as of October 1 if we don't get something coming along by next Thursday. With that, I'm going to well, let me begin by, before I even do that, let's go ahead and do polling question number 1 before we forget it and before you forget what we talked about. Polling question number 1. The failure to act on PAYGO before the end of the fiscal year would result in a mandatory cut in Medicare spending of what percentage? And either 6%, 4%, 2%, or you're unsure. Please respond.
We need some Jeopardy music playing
Yeah.
here, Kathy.
Dun, 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 dun. I don't know if Jeopardy is a good one to use right now.
Maybe Risk. Did Risk have some music? No. Now I am showing my 75-year-old age, right?
Absolutely. That's okay. The majority of you, actually not. Well, the 4% is the correct answer. The 6% was stuck in there as a just
Trick.
A trick, Sean, because if we look at the potential of sequestration as well, then we could be getting up to the 6%. So again, I encourage you to watch the news as we go forward this week. So with that, we're going to jump to another issue, and much of this I get to punt to Sean, but the Florida chapter, particularly at the spring meeting, surrounding the No Surprises Act. But there's now an interim final rule that we didn't have before. We've got some surprise. It said no surprises, but now we have some surprise FAQs that were jumbled in with another issue, which was the transparency and coverage issue for the payers. There were some surprise billing issues addressed in that FAQ document, and that impact implementation going forward. So Sean, I want to start and ask you if you would discuss the interim final rule briefly, as well as the FAQs. And then last but not least, my question for you, is there going to be a delay in enforcement?
Great. Well, let me get my crystal ball out here and dust that off, because I haven't used that in a while. So, so yeah, let me do a recap of the interim final rules that, let's say, have come out so far, and kind of what we're waiting on pins and needles again from the tri-agencies on what they'll be issuing, hopefully sooner than later. But that first interim final rule that came out, that's supposed to go into effect January 1st, mostly for the provider side, no billing, no balance billing of emergency care across the board. Then emergency care, post-stabilization services. Under certain circumstances, of course, providers can balance bill on post-stabilization services after the patient is stable in the emergency care situation. but several things, are allowed to must happen in order to balance bill that patient and get a consent and waiver signed. The assessment of the ability to travel by the attending or the treating provider. They must determine if the patient can travel, and then can they travel using non-medical or non-emergency medical transportation to get to that available participating provider or facility within a reasonable distance. So, that's going to be a challenge for providers to assess, and they need to take into consideration, the socioeconomic factors, as well as the medical condition of that patient that they're treating and is now stable. Patient's condition is another qualifying factor in order for the clinician to, transfer that patient. The treating physician must also, determine whether that patient's condition is worthy, is allowable for them to possibly give consent for balance billing. What's the turnaround time on care? What's the culture and contextual factors, such as literacy and the language that's being used in the waiver and consent? Is the patient able to understand that language and that what they're giving up or what they're signing at that time? That needs to be taken into consideration. Providers must use the standard notice that's furnished by HHS. And if any of you have read through that notice is really a cautionary tale and a cautionary warning to patients. Make sure you know what you're signing. We're not real happy with the wording on that notification, but it is very cost and price focused. Has nothing to do, does not talk about continuation of care, does not talk about quality of care, in-network care. I mean, it does talk about in-network care, but continuation of care there is not really focused on really heavily in that consent and that waiver. And then, I think the biggest issue and one of the largest stresses that HFMA put in our comment letter due to the No Surprises Billing Act, the first interim and final rule, is that verbiage in there that the consent and waiver needs to be presented to that patient that just became stable 3 hours before you provide care. Now, they're saying 3 hours, but in reality, it's at least 4 hours, because it's going to take you a good hour to prepare your best faith estimate, include that in the letter, do your research on what the authorization standards are for that health plan that patient has. So you're looking at a 4-hour delay in care after you present that consent to that patient to sign. So you have a patient hanging out in in an emergency room setting, most likely, or a very busy outpatient setting or observation setting for those 3 to 4 hours. I think one of my key comments in the letter that I tried to nail home is really this, this surprise billing consent and waiver. We understand that it's important for patients to sign, but this is not really that much different as far as a warning to balance billing, as we've been providing all along in our ABNs. Limit that is set on an ABN. You do not have to issue that through a strict 3 to 4 hours before starting services. So maybe coordinate that language a little bit better, and maybe relax those waivers. So if the patient is seeking care, they can get it in a timely fashion and be completed there. Any thoughts there, Kathy, from you on that 3-hour window?
I think the more I think about the 3-hour window, I look at the fact that you are going in, and I'm going to use the example of an outpatient service, that you are going in to be evaluated and the physician identifies that this is something that we can go ahead and do and we can take care of it today. However, where's the patient going to go for 3 hours? Doing a minor procedure, maybe they can't eat anything. Okay, here in, well, I guess all over the country, but I recognize it particularly here in Florida. Last summer, earlier this year, we had instances where you went to an outpatient clinic for service and you checked in and then you went and sat in your car until they texted you and said, you can come in now. And they waited for you at the door to make sure you were. What are we going to do? Tell them to go sit in their car and wait, go back to the parking garage? people don't, because of COVID, because of things that we've learned in the last 18 months, people don't want to sit in the waiting room. And we don't have, in most instances, we don't have the space to allow the patient to go just stay in the room. Think about them continuing to occupy space in the emergency room, whether it be in the waiting area or in a care area. We don't have the capacity for that for a continued period of time, 3 to 4 hours.
Yeah, I agree, Kathy. Yeah.
And I think patient satisfaction will be that way.
Right. And I do think there's some significant issues. I mean, not to upplay this and not to put on the provider hat and be yelling, but I do seriously think there's considerations for patient safety here in that 3 to 4 hour delay as
Absolutely.
well. I mean, there's valid concern that we all have. And I hope that those came through in your comment letters and we get some direct answers from CMS or from the tri-agencies on this. In regards to non-emergency, I'm sorry, go ahead, Kathy.
I was just going to say, I really hope that individual providers did come. And for those who represent the sponsor community within HFMA, I hope you also, even if you weren't commenting for your organization, commented on this rule as an individual and as the consumer, because it is so important that this be done right. And I can tell you, and I don't know if you were going to get into this on the FAQs, Sean, but the thing that I'm very frustrated about is we have FAQs that have now been issued that delay so many of the things that the insurance companies were required to do related to no surprises. They don't delay anything that the hospital was required to do. And I thought I was going to probably lose control there for a little bit when I read that it was because the insurance companies have had so much they've had to deal with over the last year and a half related to the pandemic. Excuse me, who's been dealing with the issues related to the pandemic? I really think it's those of you who are, as opposed to the insurance company IT folks.
Yeah, no, I agree. Yeah, the FAQs are, there's just so much coming out right now that, stoke some feelings that maybe we don't want to talk about right now. But I know I agree with you, Kathy, completely. In relation to non-emergency care, please note that, there are some services that are forbidden regardless to be billed, balance billed because of surprise billing, ancillary services for emergency medicine, anesthesiology, pathology, neonatology. These are, and then there was a request in the interim final rule to expand those ancillary services and for comments there. But keep in mind, there was also a request there for comment on the list of ancillary services that were not allowed to surprise bill. So hopefully they may consider some of those that we wanted to ratchet down and be able to surprise bill or at least recoup some of the money that, that we've provided services on in a fair manner from the payers and the patients.
I'm looking forward to reading the comment letter by the anesthesiology group, the association. Because that one is huge, and I understand, forgive people who are doing the yard in the neighborhood, okay? I understand that many times a patient cannot consent for anesthesia. Many anesthesiologists do not contract with anyone, but all of a sudden we're dealing with this whole group who are going to either have to go to dispute resolution or something to argue to get a good payment.
Right, absolutely. Or yeah, we'll get in that in a minute, but I have feelings about that too. But and there's also items and services provided by assistant surgeons, hospitalists, intensivists. Those additional folks, those services cannot be surprise billed either when performed in a non-clinical setting or a non-emergency care setting. So those are some other considerations to look at when you're thinking about the providers that are falling under your facilities that may not be able to bill in these certain scenarios. What are those agreements that you're going to make with them? How are you going to offset, if you choose to, how are you going to offset for their services and their lack of payment? I mean, in my mind, and talking to some of our members, some of our hospital folks, I think that they're very worried about those conversations that they're going to have with some of their non-contracted anesthesiologists, and what more burden, financial burden, the hospital is going to have to take on and arrange for in direct contracts with these folks to retain their services, to make them whole for their services that they provided for the hospital.
That's exactly it. They're going to want to be made whole.
Absolutely.
And there's only one deep pocket to do that.
Yep.
It's getting
Diagnostic services, including radiology and lab services, those are also not up for balance billing, even in a non-emergency care situation. And then, of course, the same notification and consent and waiver needs to be sent to the patient. Wait 3 hours, 4 hours, in my opinion, and then the care can be sought. Of course, you can get that out to them earlier. 72 hours, I think, in advance is what's recommended for a non-emergent service to be signed and returned to you. There's just a lot of challenges here with these proposed rules, with this proposal and this interim final rule, that I think hospitals really need to think about how you're going to handle these, how you're going to address these, how you're going to prepare yourselves for these conversations with your providers. Because as I'm talking to some of our members, the providers are not looking at this stuff like you are. I mean, they don't have time to, well, none of us have time to do it, but it's probably going to be you educating them on, the providers, you're both contracted and non-contracted providers, on the hoops we need to jump through now to implement these changes. So some things to think about there. There's also in that initial rule, there's a QPA calculation that was put out there. And there's several issues that we had with that. Failure to account for different facility types. Yes, they make a determination between freestanding emergency centers and hospital emergencies.
Sean, what is QPA?
I'm sorry?
What is QPA?
Yes, what is QPA? I'm sorry. that is the payment amount. The payment amount calculation.
Qualifying payment amount, yes.
Yeah, qualifying payment amount calculation. So lots of things to set that median payment rate that we're not completely in agreement with. The carving out of quality bonuses for value-based initiatives. They don't want to include those quality bonuses in that QPA, but at the same time, hospitals are receiving those quality payments because they're reaching those benchmarks. So those should be included in that average payment from that provider. Otherwise, you're going to be losing all that additional funding, and reimbursement that you should be getting for those services. So that's one of the things. Another item that they're eliminating from that QPA calculation is, and this was a little bit of a far-fetched to me, large health system contracts. They feel that if a health system is really large, those contracts and those rates that they secure are a benefited rate because of their market share, and those should not be considered in the median payment for the QPA setting rules. And there's just so many issues with that stance, and you're carving out a great majority of our contracted rates if you're not considering those large health system contracts and those payment rates. So that's another area that we have deep concern over. And then one of the questions that we have, although I'm pretty sure I probably know the answer to this, but out-of-network plan rates that are subject to notification and consent requirements. So pre-negotiated out-of-network plan rates. So patient knows what their out-of-network percentage is. That's already been prearranged with their employer group's plan. Are those subject to surprise billing regulations? Those are rates that the patients are aware of. They agreed to, they have out-of-network benefits. Is it really a surprise if the hospital applies those pre-negotiated out-of-network benefits and bills the patients appropriately? That's a question that the tri-agencies have not answered yet. And it's one that we have submitted in our questions. So things to think about there and to watch for. Hopefully they'll be updating those FAQs, but some more, because I thought the FAQs from the provider side were very weak. I mean, to give us additional guidance, but things to consider there. And this is just part one of that interim final rule. We're not getting into the latest.
Part 2 is at OMB right now.
I'm sorry?
Part 2 is at OMB right now. So stay
Yes.
tuned. We will have another rule to read.
Yep. So then there was another additional, some additional regulations that came out regarding the enforcement of patient billing requirements. And those provisions are supposed to be the enforcement of the No Surprises Act and the interim final rules are supposed to be done at the state level. However, keep in mind that only 33 of our states have comprehensive and partial billing procedures and protections. So 17 states are not currently in this space to monitor, to enforce surprise billing. So we're not certain how prepared they are to take on that additional burden that the feds, that the tri-agencies are putting on them. I guess CMS will be putting on them. But at the federal level, CMS will be the ultimate enforcer of the No Surprises Act and these interim final rules. You know, a state's enforcement of surprise billing regulations can also apply to providers who are providing telehealth services. Let's say, Kathy, you have a company that's not located in Florida, but is providing telehealth services in Florida. That No Surprises Act, they're saying that should be applied to those providers that are even out of state and providing telehealth medicine or telehealth services within that state. So HHS is currently seeking comment on this key point because many states don't require licensure of out-of-state telehealth providers. So they're not sure how they're going to mandate that. So I don't know I'm not sure if Florida is a state that requires licensure of telehealth.
That I don't know. I
Okay.
can't answer that.
If you don't know and you're in a state that you're not sure of, it might be something that you really want to look at to see what your liability is at the hospital. If this is a service that, has been an extension of your arm, to take a look at that and see what those requirements are, and watch to see what the tri-agencies come back with on that comment. Okay. So
One of the things I wanted to mention, one of the things I wanted to mention on this, with the FAQs that came out that were targeted for insurers, once more, they came in and said that because of the requirements under the law for an advanced explanation of benefits, that's delayed at least until July of next year.
Yes.
I guess I'm confused. And if I don't have to do this. Y'all do. You're the providers. But my question is, I have a patient who presents who is out of network and wants to have the service. It's a non-emergent service, but the patient wants to have the service provided by the facility or by the physician on staff. It is an in-network facility, out-of-network physician. He needs to explain to the patient what they're going to be billed in order to get that waiver or that consent signed. But the whole concept of the advanced explanation of benefits and submitting information, basically this FAQ said that providers need to submit for estimates for uninsured individuals only, which I'm not sure who I'm submitting to if they're uninsured. But for the insured patient who is out of network, how do I get the information about their deductible co-insurance based upon the qualified payment amount if there's no method to submit it? It seems like they stop things on the insurer end, but they didn't stop it on the provider end.
That's right, Kathy. I mean, it's essentially all the hospitals are going to be able to do until this gains traction, moves forward on the payer side, in my opinion, is provide those good faith estimates. I mean,
of what?
as they would with any transparency case, though.
Well, because if it's good faith estimate of what the patient owes
No, wouldn't, I mean, it couldn't be
of
because you have
charges.
no idea.
Exactly. And so then how I guess I'm providing a good faith estimate of my charges, but I have no idea what you're going to be billed. And then you wind up getting a bill that was greater than you thought it would be. I think stopping things on the payer side just put a major wrench in the hospital side.
Oh, absolutely. I agree. You know, there are several things that were provisions that were delayed in the FAQs. You know, they're good faith estimates on the payer provider side were delayed. You know, as Kathy said, the advanced explanation of benefits were delayed. Health plan machine readable file in and out of network processes were delayed. The health plan price transparency tool from the plans and from the payers was delayed. And then the health plan, I think it was the machine readable pharmacy file, pharma file was also delayed until at least July 1st. There are some things that were not relayed or delayed. I think a few were gag clauses on price quality data that was still in there. The accuracy of health plans and providers directory. So that'll be interesting to see how payers and plans clean those up. Continuity of care was not delayed. Those parameters. I think grandfathered health plans weren't delayed, and then I think it was the reporting of pharmaceutical benefits, benefit costs were also not delayed. But I agree with Kathy. These are things that I don't want to say hospitals are dead in the water for moving forward with their piece, but it certainly does make it a lot more complicated and places a lot more administrative burden on the hospitals to develop workarounds either internally or with their payer plans that they do a lot of work with to even come close to even trying to achieve the no surprises, you know, interim final rules. Wouldn't you agree, Kathy? I mean,
absolutely. And I am so looking forward to part 2 of the interim final rule, just to find out if they answer any of these questions. If it's strictly focused on the dispute resolution process, it's not going to address the issues we've got to deal with before we can get to the independent dispute resolution.
yeah, I agree.
So let's take a minute and go to, I guess before I go to the polling question, I want to get ready for polling question number 2, but I saw that Matthew had a question in the chat related to PAYGO. So let's go ahead and look at that. It says, if it goes into effect, will that impact dates of service 10/1/21 forward? That is my understanding because it would be with the new fiscal year. And has there been any information on how that reduction will be identified in the remit? I'm going to be very blunt with you, Matthew, and what I'm going to say is you're going to get the same remit with the same payment until they figure out how to do it, and then they're going to be coming along and taking it back, because there is not currently a way to address this separate from sequestration. They could merge them together, but we don't have sequestration right now. That's been delayed. So they're going to have to come up with a code, a way to do it. I vote that we're going to be doing reprocessing of claims if this goes through. We just need to make sure that hopefully this thing gets addressed through Congress. We've got this law. I think it's only been once or twice that it's been implemented, and only for a very, very short time. But actually done retroactively, if I think about it. But we need to, there's too much struggle going on in DC right now that I'm not sure what we're going to wind up with. So let's go to polling question number 2.
I would agree, Kathy. I think that, you know, if this doesn't get approved, what I would do if I were back in the hospital and in operations, I would immediately reach out to my provider relations rep at my MAC and start the conversation right away. How are you going to deal with this? You know what I mean? Just to start that conversation with them, because it's going to be coming from them.
So that they start asking that of.
Yes.
There, okay, up the ladder.
CMS. Yep.
Okay, so the polling question number 2. Again, trick question. What is the minimum delay in care required by CMS after a patient receives a consent to be billed in excess of the in-network deductible and co-insurance under the No Surprises Act. 4 hours, 3 hours, no delay in care, or unsure. And the are 3 hours. Again, good job, folks. We that between the 3 and the 4, tried to trick you, but can't be tricked when you're in HFMA. So we've got 2 more quick issues that we want to discuss. So I'm going to, again, we kind of touched on it a little bit, that there have been delays related to transparency and coverage and surprise billing from the payer perspective, but hospitals are still faced with be compliant with transparency, the posting of the machine readable file, and the shop services. It's we're facing an issue where CMS has proposed a change in the penalty for non-compliance with that rule. Sean, can you address what that proposed change is? And is there going to be any real enforcement? I can tell you, let me just jump in and say part of the question, that because it was going to be addressed to Jamie, was where Florida hospitals are related to compliance. Based upon what PYA has identified, we have over 175 hospitals that within the state who have reported their negotiated rates, and that it's out there and accessible. We are moving along. That's a significant increase from where we were 6 months ago. Anything on the potential additional penalty?
Sure. So the potential, penalty was really kind of stated there in the OPPS rule that just came out, the proposed rule that we've not submitted. Probably most of us have not submitted. We did submit comments last Friday. I guess I sent those in last Friday. So, gosh, I'm telling you guys, the days run together these days. I'm so crazy here.
It happens. 5.
Right. So the increased civil penalties, which of course, in their infinite wisdom, the tri-agencies came up with yet another acronym. CMPs is what it's being called, just in case none of you guys dialed into that. For non-compliance with price transparency requirements, the agencies will, or CMS will issue a provided written notice to the hospitals, the very specific violations. I do have members that have received these over the past 6 months. I can tell you that just this week, I talked to some folks here in Nashville. I'm in Nashville right now at a conference, and several of the hospitals here had received those written notifications. Some agree with the written notifications and the exact specific violations that they received from CMS. Some do not, and some did not, and went back to CMS to discuss those with them. And they found that CMS was wrong and the hospital was indeed correct, and they had not violated the price transparency rules. So definitely, if you do receive letters from CMS, and you believe that you're not in violation, have those active have that active dialogue with them to discuss those issues and make sure you understand why they're submitting that letter to you. The second step in those impacts to fines is they will request a corrective action plan from the hospital if its non-compliance constitutes a material violation of one or more of the requirements. Then they will impose a civil monetary penalty using a scaling factor, was their final determination in the OPPS final rule, based on bed count or hospital revenue for non-compliant hospitals that fail to provide or comply with its corrective action plan. And then they will publicize on the CMS website the hospital that has been assessed a CMP for failing to comply with price transparency requirements. They did actually come out and say that forensic hospitals, state forensic hospitals, are pretty much exempt from price transparency rules and regulations because they're already publishing their prices out there and they meet the price transparency requirements. And then they strongly prohibit certain conduct that seems to assessing the standard charge information. So I know that some hospitals have chosen to block that download, that automatically scrape download from the internet. I think CMS is very aggressively saying this is not acceptable, and you probably will. My guess, Sean Stack's feeling is that you would probably be fined for that. They're going to come out and fine you for that. They're saying that's not acceptable. What are your takes, Kathy, on that? I feel that there's so many gray areas still with hospital transparency, and there's still much more clarification that needs to be done from the hospital or from CMS, that these penalties are a little egregious at this time. I do feel that they have covered in their proposed rule for OPPS to, I think the clear message there is that they want to work with the providers to resolve the problem. I will give them that, but I still don't think there has been enough clarifying work and clarifying policies and clarifying FAQs placed out there for hospital price transparency to hold hospitals this accountable and fine them this high.
Wholeheartedly, Sean. First of all, increasing the penalty isn't right. You have had other things going on for the last year and a half. And we're just really learning what compliance is. And what really worries me is there is one hospital that I think is probably on this call right now that I have actually looked in great detail at their data. It is such a great looking file. I would really someone to come back and say, we want everybody's to look to adopt this format. And no matter what you've already posted, we want it into this format and put your columns and your rows this way. Because a lot of time doing this, and now if they come and mandate a particular format, not a file type, but the layout of the document, we're going to be recreating the work. As a matter of fact, I just wanted to mention there was a report that came out in July. This is the semi-annual hospital price transparency compliance report, and it was published by patientrightsadvocate.org. You might be familiar with them. They're the ones who had an ad at several events earlier this year informing patients of their rights related to price transparency. If you look, what they did is they analyzed 500 hospitals just across the country. And they said that 94% of those hospitals, 471, did not post a complete machine readable file. But then they went on to say, here's how we're defining a complete file. And they said, first of all, you did not include all payer specific plans, negotiated rates. How do they know? How do they know who you have contracts with and that you have all individual, not only payers, but individual plans? And then they said that they found non-compliance due to fields with zeros. Is that wrong? NA in a field, N/A, not out in a field, or asterisks for negotiated rates. Those were considered wrong. If you went to CMS, if you participated in CMS's web that they held, I believe, in August when they did a refresher on transparency, and you looked at the screens that they showed with this is what in it, they've got zeros, etc. So these were things that hospitals were criticized for by patients' rights. This was picked up by media saying all of these hospitals are non-compliant, but waited with was not the appropriate criteria, not what CMS is evaluating on. So I would be hesitant to say, if you see someone sending you a report saying we think non-compliant, unless the initials are CMS, standing for the Centers for Medicare and Medicaid Services, or HHS, standing for the agency, I think I would be very, very cautious of making changes to the file that I've already posted. We've only got about a minute, so I want to jump to the last question, and a question that some of the issues that I think under the public health emergency, we changed the way we did business. There was major expansion of some of the ways. Get one for a minute. Well, let's go ahead and do the polling question. The polling question is, has your organization developed a strategic plan to continue or implement programs long-term following the PHE? Are you looking to expand telehealth going forward? What about hospital at home? Registration and scheduling? More than one of the above or none of the above? If you did that, then I want to get Sean to identify which of these is his favorite, and I will do the same. More than one of. All right. There is no right or wrong answer on this one. So Sean, out of these, expanded telehealth, hospital, online registration, or scheduling, which one do you like the best?
Well, I don't, that's hard to say because, you know, they're all three so different.
Maybe I should do it this way. What do you really want to see continue more of as we move forward post-pandemic?
I mean, geez, Kathy, put me on the spot. Well, I truly think that all of them are very important. I think online registration and scheduling have so many benefits to hospitals. You know, the online registration and scheduling, you know, whether you're using the Epic Hello app, what you're using, if it's successful for you, I think it really has a multifaceted approach to addressing so many issues that hospitals are facing right now. Staff shortages, it really helps you fill in that staff shortage of having folks offsite, if at all possible, to help schedule and to help register folks virtually, which I know several hospitals and several members that have spoken to me are doing and doing fairly successful. I think the biggest hurdle there is getting those armbands printed and having the nursing staff or the clinical staff in the clinics print those armbands because the registration folks are not there in person to always print those. So that's a hurdle that a lot of hospitals have had to overcome and have actually overcome in that process. I think that my most passionate program out of all three of those areas is hands down acute hospital care at home. It's
I agree.
Yeah, I mean, it's just the right, you know, I'm becoming older. I guess I'm over 50 now. I just turned 50. It's something that I feel is important for the continuation of healthcare, where we want to go with healthcare in this country. I know it's strategically very scary for a lot of hospitals, and they are really working through that now. There's a lot of upfront cost in setting up those programs, you know, doing all that case management and work out front when a patient is going to their home. I think there's just a lot of upfront expense in setting up those programs, not to mention the movement in revenue from that hospital to that inpatient care setting at home. You know, factors such as hospital acquired conditions will probably most likely still acquire when that patient is being seen at home through acute care setting. Now, telehealth, I look at telehealth services a little bit differently probably than I think most people do. I look at telehealth services for the most part as a supplement to clinical care. I don't think it's not taking the place of going to a doctor's office and really having an assessment done by a clinician. I look at it as expanding the services in the hospital to those folks that may not be able to come in at the frequency that they need to come in, but they're still coming in. I don't know if you look at it that way, Kathy, but I think it's not to replace that face-to-face contact in its entirety. It's to supplement and help folks stay on that healthier path in treatment and follow up with their clinicians. Would you agree?
I absolutely. I think the proposed physician rule as it relates to continuing and expanding telehealth for mental health services is huge, because it is a great way to reach people who really need that help. But there is the requirement that as a precursor, you have had the face-to-face visit, and that there are ongoing face-to-face visits. This is just another opportunity out there. I think that is very important. I will speak from the perspective of Medicare and say, once Medicare beneficiaries have used to telehealth, it's going to be hard to take it away from them. I wanted to go back and address the issue of hospital home. And I have been absolutely fascinated by this. I know that there are a few hospitals in Florida that have begun implementation of hospital at home, but what we're seeing in terms of outcomes to this is basically, this is inpatient care. Patients in the emergency room, they're diagnosed with pneumonia, they're sent home as an inpatient at the hospital. But we're seeing patients with better clinical outcomes, shorter lengths of stay, lower overall for that patient's care, fewer complications, greater satisfaction on the part of the patient. We watched there was a clip from CBS News a while back where they were actually going through the visit to the doctor and the nurse. And I was absolutely fascinated with the fact that this had gone to the emergency department. She was diagnosed with pneumonia. She was home. She's moving more. And they had monitors on her and things like that, where they could tell that she was getting more movement than she would have if she had lain in the hospital bed and waited for someone to maybe come and walk her down the hall. She wanted to drink of water. She got up, she went and got a drink of water. She stops, the video is great. She stops and pets her dog, which as a dog lover, I mean, that was cool. I don't want to be away from my dogs. My husband is one thing, but my dog's different. But I really think I think it is very important that we consider that ongoing at home. Someone asked in the chat, who is doing this? I will have to get you a full list. Email me, Christina. I will see what I can do on the list here in Florida. There is an organization.
Kathy, that list, if you just Google CMS Acute Care at Home, CMS has a website for acute care at home. To the right, there is a link that will list all the hospitals that have applied for the CMS waiver. Now, I want to tell you that I know personally there's a couple on that list that have applied for the waiver, but they haven't done the program yet. They haven't started up their program yet, but they've applied and been approved for the waiver. I want to say it's around 170-ish hospitals in the US. I also want to say that this is not a new program. This program has been around since the 80s in the US. It was started as a VA pilot program.
Right.
And then it started to be a managed care, Medicare managed care program. HFMA, I coordinated an interview, and Kathy has met the lady or talked to her, the doctor. Dr. Descheri is one of the pioneers in this area. She is going to be doing a full page, full article interview. I think she actually is the cover of the HFMA magazine in October. So that will be coming out. And what we're trying to do is wrap up those interviews now. And I have some coordinated new hospitals, some hospitals that just applied for that waiver, to kind of give a perspective of, this is Dr. Deshree's history with the program. And she's seen, like Kathy said, better outcomes, less cost overall, better patient engagement, better patient satisfaction, and better clinician satisfaction. Mm-hmm. Clinicians that have been participating in this program absolutely love it because they know they're making a difference in these folks' lives, and better case management satisfaction. Kathy talked about the dogs. When hospitals are assessing for this program on site at a home, they're going through the patient's medicine cabinet. They're seeing where their drugs are located in the house. They may be looking at fall hazards, things that are really going to change the health, not just the health care of this patient's lives long term, and making them aware of those environmental factors in their home. It's just a win-win for everyone. I don't know if Kathy's experienced this, but I think the only program I have felt this passionate about in the last 25 years of my career here in healthcare has been the PACE program. The Medicaid PACE program has a very, very similar approach to that, leaving patients in their home, especially the elderly, and giving them the services they need by going to a community center. This is very much that feel. It's not the same thing, but it's a quality of life, total health feel. Wouldn't you agree, Kathy?
Absolutely. And I think the one thing about this, ultimately, as the managed care payers are starting to adopt it, this becomes something that reaches a younger population. These are inpatients at your hospital. You're not going to be dealing with this discrepancy in reimbursement, but these patients are going to learn how to better control their health, because it's going to be the time and at home opportunity for family to also learn what's needed. Sean, I really have to say huge thank you. I know this was supposed to be a four panel discussion. It was just the two of us, but I hope we were able to cover the topics that are important to the folks who are on the webinar. I appreciate y'all sticking out with us a little bit longer. And Anthony, I'll let you wrap up.
Sure. And thank you so much to you both. Faced a little adversity and came through huge for us, Kathy, as always. And Sean, welcome to the Florida family here. We look forward to having you speak for us in the future as well, hopefully back in person. Just quickly as we close up, you're going to receive that survey at the end of the day in about a day or so. Please make sure you fill that out. It's great for our feedback to put on some more events like this, and also it'll allow you to get your certificates. If you're not a member, highly encourage you to do so, particularly because we have these upcoming certification sessions for CRCR and CHFP, which are included, the certifications within your membership. So go ahead and do that if you were thinking about it or on the fence. Trust me, it's awesome. And what was the last thing that I'm contractually obligated to say? And then upcoming events, check us out on floridahfma.org for upcoming events. We've got another regional education virtual in October, another one in November, and a bunch of stuff coming down the line. So check us out. Thank you all. Have a wonderful rest of your day.
Next year.
Yes.
Thank you guys. Stay safe.
St. Pete. Here comes the noise.